create a small group of support for each other. And what I hear you talk about a lot with your podcast too is just the sensation of imposter syndrome, this like feeling of what am I doing? Am I like supposed to know what I'm doing? I don't know what I'm doing. Do you know what you're doing? Am I asking too many questions?
Yeah.
Hey, because we have folks that have like been here for like about a month, and this is their first month of practice, and we have folks that are in like their first 6 months, and somebody who's like reaching like the year marker, and I can relate to everything that they feel. So to say out loud for people that that is all completely normal, because I think there is still this idea that especially when you go into healthcare, that you are going to know everything, or that you can handle everything, or you're supposed to be able to fix everything. And that is not a realistic expectation. That is not fun, nor is that reasonable or what anybody has to offer, right? So,
well, hey there, it's Liz Rohr from Real World NP, and you are watching the Real World NP YouTube channel. We make weekly episodes to help save you time, frustration, and help you take the best care of your patients. So the vision I have for this episode, or I had for this episode, was for people who either are in clinical practice right now and don't have a mentor, or they're a student kind of like making that transition into new grad life. And what support can we offer for people who are in that situation? So this is an interview with my dear friend and former colleague, Kara Pesola. You may have seen her before or listened to her before in a former episode or previous episode we've made. But what she's in a clinical director position where she trains the new staff, including majority new grads. And so what I wanted to talk with her about in this kind of interview conversation was a little bit more like, what are the things that are catching people off guard in terms of the topics that they weren't ready for when they got into practice, right? Like I think that we all, or maybe you don't know this, but a lot of people have clinical questions, right, about patient cases and did I do this right? But then there are all these other tricky situations and scenarios that we can get placed in moment one on our first day of clinical practice that we're not necessarily prepared for, that are a little bit more complicated to manage. So we touched on, spoiler alert, but we're touching on things like if you're inheriting a panel of patients and you're like, what do I do here? Especially if there are controlled substances that I feel very uncomfortable prescribing. Or what if I have a patient who has longstanding diabetes that is out of target range of their A1C and they don't want to manage their condition? We also touch on a lot of other questions that the new grads that she's mentoring and supporting in their transition, a lot of the things that they're bringing, it's kind of the same stuff over and over again, which is hopefully helpful for you to hear, especially if you're in a situation where you don't have the support that you'd like to have, or as much support as you would like to have. And even if you have the support that you're like delighted with, it's still a really hard transition. So it might be nice for you to hear what are some of the things that new grads are struggling with and that you're not alone in, and how to navigate those kind of trickier conversations that you might not expect, that we didn't really talk about in school, and like how to walk through those and feel more comfortable either anticipating that will happen if you're a student graduating and entering practice, or if you're already in practice and you feel like, oh, I feel really uncomfortable with those situations. So hopefully this episode will be helpful for you. And I love my dear friend Kara, so hopefully you enjoy her as well. But yeah, without further ado, here's my interview with Kara. I'm so excited you're here again. This is so fun being with you. So can you introduce yourself again for the people? They've probably heard you on a podcast, maybe or two before, but can you introduce yourself?
Thank you for having me back. And I am Kara. I am a nurse practitioner that I've been for about 8 years now. And for this past year, I have entered our role of a director of clinical training, which for our organization is a new role. And what especially speaks, I think, to you, Liz, too, and for me to talk about, right, is like this new role for us is really developing our newest staff at the organization, that I get to help support the onboarding mainly of like new grad NPs. So I'm excited to be here.
That's awesome. Yeah, I love that. I love that you have that position and you're in it's such a good role for you. So one of the things we talked about was I love sharing the behind the scenes of what it's really like to be a nurse practitioner and like what are the things that people aren't talking about.
Mm.
I think that I know that I did this when I was a new grad where I was like in school, and I was like so scared to graduate. But I was like, no, I'm good. I got this. I got this. And then as soon as I graduated and I started, I was like, I don't have this. I don't have this. I wish that I had listened to people about getting support and all that stuff. And I see that. I've seen that a bunch in person where
Mm.
I've worked with NP students and I'm like, hey, so I have this like website and podcast that might help. And they're like, okay, that sounds nice. Thanks. And then they get into the middle of it. It's like a couple of weeks in and they're like, I had no idea. I wish I listened to you of how hard it was going to be. Right. So I think that there's like, if there are people who are going to need to hear, or who are needing this and wanting this, and there are people who are like, I'm not ready to hear this, but know that it will come back if you're not in this place, if you're a student. But yeah, I think I'd just love to talk about the kind of like intangibles of like, what are some of the things that what are like the most common things that you're seeing, especially in this role? Um, and like, yeah, just like maybe just chat about that a little bit.
Definitely.
And so you were just kind of sharing before we started recording about how you just facilitated a group mentorship session. And how was that? I don't know, just maybe sharing some stuff of like the scope of who was there and what y'all
Yes.
kind of talked about.
Yes. So as an organization, we just recently onboarded 4 new grad NPs. And for me, like I'm about 8 years into being an NP, and I still very much so viscerally remember my first year experience.
Oh my God.
Right?
I don't know if that is ever going to leave us.
I know, right? But to be able to see it again in a different light with our new people that are with us now has been really lovely, and also really like eye-opening to the things that are really hard that we don't necessarily talk about in school or
Yeah.
get to practice in our clinical. So with our group of 4 people who are new for our organization, we've been doing individual like sessions for support, and we've just started a group session. So for our first group session, just taking time to be together, like similar with you and your podcast and your listeners, right? To create a small group of support for each other. And what I hear you talk about a lot with your podcast too is just the sensation of imposter syndrome, this like feeling of what am I doing? Am I like supposed to know what I'm doing? I don't know what I'm doing. Do you know what you're doing? Am I asking too many questions?
Yeah.
Right? Because we have folks that have like been here for like about a month, and this is their first month of practice, and we have folks that are in like their first 6 months, and somebody who's like reaching like the year marker. And I can relate to everything that they feel. So to say out loud for people that that is all completely normal, because I think there is still this idea that especially when you go into healthcare, that you are going to know everything or that you can handle everything or you're supposed to be able to fix everything. And that is not a realistic expectation. That is not fun,
Yeah.
nor is that reasonable or what anybody has to offer,
Yeah.
right? So I think that's the main thing from the very beginning for me, is to like reminder for all of us. And I think at various times in life it's helpful to say that out loud, right? That no one's meant to have these answers, and that's not really what healthcare is.
Yeah.
That we have the guidelines there for a reason, the research is there, we have up to date all the things that we can check, but it's about having connection with each other, like support to go to and talk with somebody else, right? But I think that's our main theme in the beginning, right? That this is like hard work, and we're all in primary care.
Yeah.
Anything is hard, right? And I
Yeah.
really only know primary care, but just the complexities of having to feel like you need to know everything, from like what that rash is that somebody comes in with, right, to how to help with treating heart failure and like uncontrolled type 2 diabetes, right? That you're going to
Yeah.
maybe do all 3 of those in the same visit, right? So
Yeah.
that's a lot to step. Like I feel you, right? like it's the deep breath.
I know, it's like deep breath. We got it. Okay. One step at a time. All those things. That's okay.
Oh yeah. Right.
Totally. I just, I went away this weekend and I encountered a PA, hopefully she's going to come on the podcast. She's lovely, but we were talking about that transition to practice, and she just remembers having this mentorship experience where she was ready, like coming out of school and being like, well, what's the dose of blah, 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 blah for that? And she was like, I don't know. And then the mentor was like, good, I don't know either. Let's go look it up. And just like really not, and she's like, is that okay? And I think the other thing that came up for me when you were sharing about that is I think that there's not only the self-imposed expectations that we need to know everything, but I think there is a cultural expectation from people who are working with you in the clinic, whether it's like, and it's not necessarily like an overt, like you need to know this, but it's like when you have a patient and your administrative staff or your lab tech or your nurse comes to you for an answer and you're just like, I don't know the answer, but it's like that's their job, is to come to you. And like you put that on yourself to like have to know that. And like, ultimately you have to tell them, but like, you don't need to know it off the top of your head. And I think that there is an expectation for people who are not in healthcare, like patients, for example, can be surprised if you don't like I remember when I graduated from school, people would be like family members and friends would ask me all these medical questions. And I was like, oh my God, this is just reinforcing my imposter syndrome because I have no answers for you. And you just think I'm an idiot. And like, it was a big piece of humble pie, but
delicious. That's always
delicious pie. But I'm so glad that you have that mixed experience of people who are like a month in and then a year in. And then like, you can kind of see, how there's different stages of it all, but it's a very relatable experience. And it's really like, that's what I've noticed over the years, is that it's such a repeatable experience over and over and over again across the country.
Yes.
And even internationally, like most people are based in the US, but yeah.
And hearing you say that kind of makes me remember that like this experience of being new, really at anything, but I can relate to the NP experience. It reminds me of like the bleeding pattern expected with a marina, right? like you might expect like all this like irregularity and discomfort, perhaps like this is acute, right? And maybe over the course of like it's really very similar over the course of 3 months, there's like a little bit of a drop off, right? And that totally is what I'm hearing people share.
Absolutely.
Right? After those first 3 months, right? I know.
No, I love that example. I can see the graph in my mind when I was like up to date, and I tell patients, I love that.
But then after a year, things are starting to like stabilize, right? And if this is like a thing you like or maybe don't like, right? And you can decide to remove it or continue, which I think is pretty cool.
I love that. I love that so much. So I would love to talk about, so like what are some of I think that there's some really common questions that people have. And then there's kind of like some more complicated, very common, but also a little bit more complicated questions that people are bringing to you. What are the types of things, I guess maybe just normalize the experience, because people come and seek you out in individual sessions or like in clinic time as the mentor. Like what kinds of things are they asking of you? What are like the kind of common things that you're just hearing over and over again with these new grads?
Definitely. Yeah. So the number one, right, is this okay? Am I normal? Right? And the answer is always yes. And number two, I feel like is like navigating like kind of like the challenging conversations that come up. And I think that really comes up with like the complexities around treating like, let's say, I think most commonly for primary care is like diabetes, right? When somebody has like type 2 diabetes and let's say their A1C, they come in and your A1C is 12, right? And like how to like have that conversation with somebody, right? And what's the urgency level and what to do when somebody maybe doesn't want to treat something, right? Which is also completely appropriate. I think that's like the next level of questions that come up. And I think going on like off of that, I feel like after that, I speak to like all of our like family nurse practitioners out there. Pediatrics is not one that I do because I'm adult gero and women's health. But pediatrics is huge. And it made me really like see the people of knowing that like when our NP schools, when somebody's in clinicals, the amount of people that they actually have to see to like move forward, right, is not that high, right? I saw somebody was like, I think it was 4 babies. They only had to see 4 babies in order to like graduate and to move from, right? So like it makes a whole lot of sense that like to feel this discomfort with like pediatrics, right? With newborns, with like young kids, right? Like we don't get enough of that like in our practice.
Yeah. So I feel like it feels like there's a couple different categories where it's like people are coming with like a direct clinical question of like, did I manage this correctly? Or like, what would you do in this situation? Or, something like that. And then there's like this, just like fund of knowledge. I love that expression. I don't know why, but like fund of knowledge, like
Yeah.
gap where you're helping them with that. And then there's this like, am I normal? Am I asking too many questions? I have to look everything up. Is that okay?
Yeah.
And like, I feel, I don't know if this is how they say it to you, but it's like, I feel like I have to leave the room every time I come up with a plan. Like, are they concerned about that when they bring that to you kind of thing?
Oh,
Like,
yeah.
is that normal?
Yes. And I reference you for maybe folks who maybe don't know, right? Like, so Liz and I got to work with Liz when I first became a nurse practitioner, and I am forever grateful for that.
Yeah.
And I remember one of the first things that you had said to me was like do that, right? Just what you do, right? Like
Every
after
patient.
you, right?
Yeah.
Right? That you like say, great, okay. And you kind of sum up what we did, right? So we talked about like your blood pressure and your back pain, I'm just gonna go look up like what medications we're going to do, and I'll come back and we're going to like review it, right? That's the expectation, that I leave
Yes.
and then I come back, right?
Yeah.
And I also like add for people, I had a preceptor that always told me that when she's listening to people's lungs, that's when she like also takes a deep breath,
Yeah.
right? And then she remembers like, oh, these are the things that we are going to do if I need a moment for myself. But I share that like with everybody, right? That is the normal, to leave the room and to come back. Right?
Yeah, those like two norms of like, I'm going to leave the room and come back, and I discuss it openly with the patient, comfortably, confidently. I mean, I've like had maybe one person question me in like a million years of practice, like,
Yeah.
right? Like
Yeah. No.
people don't care. They're like, okay, that's fine.
Yeah.
They'd rather and feel confident and take care of them and be attentive than to brush them off. And
I
then
bring up
like,
up-to-date algorithms in front of people, right?
I'm sorry.
Just to say it, like I bring up like the up-to-date algorithm,
Yes.
like in front of somebody, right? And that's like, so I think people also really like that, right? That it's like normal. And I think myself as a patient likes that too, right? That like we're talking this out together. I'm like, we're letting them know, we're keeping like they're a part of like the discussion, and you're showing them that this is what I see, right? This is where you are, and this is what we're thinking, right? That's like really helpful for people.
Such partnership. Yeah. I love that. And then just like adding in, I wish I had done that so many years ago. Like when I like me taking the deep breath with like, that's so brilliant.
Yeah.
Cause that like really like, it's one of the quickest ways we can calm our bodies down is to take those deep breaths and those diaphragmatic breaths. And it might not always be accessible, right? It might be that kind of shallow chest, upper chest breathing because you're so stressed. But even if you're not coming up with a plan, even if you're like, I need to go look on UpToDate, like I can breathe in this moment. And it's going to take me how many extra seconds to do that. Excuse me. I love that. So it's like, just kind of coming back to that, the normalization of like, it's so normal to ask a million clinical questions and to doubt yourself because you're so used to, new grads are so used to having a preceptor approve everything.
Yeah.
And that takes a while to trust your own judgment and your own decisions. Yes. And then you also have the like, those kind of common things of like looking everything up and having all those questions, and all of that is normal. And then I think that the third thing that we had kind of talked about before was getting into those more complicated questions that snuck up on me. And I think that you probably still see that. And then I think you had that experience too. So I think maybe three, I'm looking at my notes here, but I think the main three things we talked about is like, what if somebody has a condition that they don't want to treat? How do we manage, like, I think that the overarching theme is like stepping in as a new provider when some provider has left. Not everybody has that. Sometimes people get hired and then they build a brand new panel, but a lot of times people are stepping into someone's old panel, and it's like, whether it's controlled substances or a certain way of managing their chronic condition. I'm only thinking of two, but I think those are the two main kind of overarching things that kind of sneak up on people that you have a little bit longer discussion. That's not just like, oh, like, lisinopril 20 milligrams is great for this patient or whatever. You know what I mean? So So what do you, which one do you want to kind of touch on? Like, do you have any, I don't know if you have any examples that come to mind, but it might be helpful for people to hear that this is something that will inevitably come up, whether it's day one or however long.
Yes.
Which one? Do you want to start with the management choices?
I chose the other one actually.
Go for it. Go for it then. Go for it. Okay. Absolutely.
I feel like controlled substances, right? And like, or
Yeah,
like
if you
what
want to
that's,
like start with a context patient too, or like just like a
oh,
general,
yeah.
that would be helpful, I think, for people, especially if they're like, if somebody comes in and I guess maybe I'll give an example. So I had
Yeah.
somebody who came in for their I'm trying to remember the context of it, but basically they had like multiple times a day a controlled substance, pain medication, had been on it for years, had seen this other provider for like 3 or 4 years, and is just coming in for their like monthly, like the schedule this provider was on was like a monthly. Every month they come in and they do a med check, quote unquote, of like they just like have the conversation. Here's what they usually talk about, and then they refill the meds, and then they're good. Or it was a schedule of like every 3 months or whatever. But the context is somebody's coming in a little bit hot, I think, as we talked about before, coming in with some heat of like they're, yeah. I
Why
mean,
are we doing this
they're kind of
different?
angry. They're kind of upset because like their provider has left. They have this controlled substance that people give them a really hard time about, generally speaking, whether it's the pharmacy, whether it's the provider. And they're just like, who are you? Brand new grad. You're gonna give me my meds. I'm ready to go. Right? Like, I mean, those are just the ones that I was like,
oh yeah.
What do I do?
And I know we've talked, like I remember like my first like week like of practice walking down the hallway to like start like Suboxone, and like which is that is the easiest controlled substance to do, quite honestly, right? But I just remember that like, oh, I have not had this conversation before at all, right? This is like just in that same context, like you're saying, they're seeing somebody else, they're already a little upset because like it makes sense, right? They're so nervous that someone is going to stop something, right? So like to remind ourselves is like what is behind that like anger or that like them coming in upset, right? But like yes, going back to what you said, right? So what do we want people to like hear from that? That you might have a panel of patients that maybe you inherit, right? And folks are maybe they're on like opioids for pain that they've been on for years, and maybe the last person had a different idea of a plan than you do, right?
Yeah. And
or
like
maybe,
you're coming in of like, here are the guidelines, here's a recommendation. I'm terrified to prescribe this controlled substance, whether it's pain or something else. And like, this is a higher dose than I feel comfortable with, that I think they should be on, or X, Y, and Z, whatever you're coming in with in terms of you're like, I am so terrified to be doing this. And then here's like what I know from school. And then you have this person who's, you know, before you is just kind of like, this is how they've managed this patient. And you're like, I don't know how I feel about that.
Yeah.
Like, and that's my license. And it's like, I've been here for a week and you want me to prescribe how much oxycodone for you?
Yes.
How much Dilaudid for you? What?
Yes, right. And your clonazepam too, right? So total like, and like hearing you say that again, like is really helpful to put it in perspective, that is a really normal and appropriate response to like feel that way, right? Because that does feel risky, right?
It feels so scary especially for a new grad. And to see like the combination of an opiate and a benzodiazepine is like,
you've already got like the box warnings coming up, right? And the DEA, when you've gone through the whole process, has probably scared you, right? That you're going to like have your license taken away by whatever, right? So appropriate to have all those feelings, and also appropriate to like continue someone's existing plan, right? That's kind of like what I've come back to with people, right? That like the first time you meet somebody is not like when you have to then change something, right? They've been on this for some time, right? What's like appropriate is to continue and have a conversation and to make your plan about what it looks like for you and that person looking forward, right? So I think that was the first question, is like, can I continue this? And the answer is yes, right? Unless there's like a red flag, right? That like we're concerned about the person's safety with like using the medications, right? We want to make sure that like they have all of what your policies are with your organization, right? But they've had like their routine like screenings for the urine drug screen. They have their controlled substance contract. All of those things are like in place. But like first visit is you continue said plan, right?
Yeah. And it's basically a safety assessment and continue.
Yes, right?
Yeah.
And you like your relationship building, which I think is like, that is of course the most important part. And I find that I also just acknowledge always like the discomfort in the room, right? Because if somebody is coming in, they're meeting you for the first time and there's controlled substances, they're already coming feeling anxious that you might stop them right away, right? Because they've, like you said, they've had that experience everywhere they've gone, and they feel like they might feel like really defensive. And I would feel the same way, I'm sure, in that position, right? Because you've been forced to like explain yourself in very different ways, and you're treated differently because of the medications that you take,
Yeah.
right?
And there's
That
a lot of
someone in our
bias.
profession prescribed for you in the first place,
Yeah.
right? Yeah,
Right.
right. Tons of bias, right? So
Yeah.
like to encouraging people to like take a moment, right? That this is appropriate to keep doing. And it's appropriate to make sure that we are, like you said, doing the safety assessment for somebody and then having those like goals of care conversation there, right?
Yeah.
Like, what is this medicine like bringing to someone's life, right? Is it improving someone's quality of life or maintaining a quality of life? And that's what helps kind of guide the conversation after that. But for you and that person, like, yes, you are new. And I always acknowledge that with people. Like, this is our first time meeting, right? This is like, we're not changing things today, right? Unless that's something that we decide that we both need to do. But our
Yeah.
plan is to like talk about this together and to make our plan going forward.
Yeah.
And that I think is the biggest piece. And
Yeah.
that's hard, right? And I think it's hard like for our organization, right? Like we, especially after COVID, right? Things like really changed during COVID. We had a lot of our folks like we went full telehealth for a long time, which is wonderful. And it also brought up some stuff for our folks with controlled substances where we hadn't
Yeah.
seen people in person
Yeah.
for a long time, right?
Yeah.
And then that's also what the standard was. So then people felt really uncomfortable that we were asking them to come in,
Yeah.
right? So as an organization, that was our first like hurdle to kind of
Yeah.
pass and to remind people that, oh, now we're going back to like what our standard is, right?
Yeah.
So that the being clear is kind is a message that I hear a lot from our folks here. And I really resonate that, especially when it comes to like controlled substances, right? That this is what we're doing today. And
Yeah.
this is what our plan for follow up will be, right? Of
Yeah.
knowing that like this is when I'm going to see you again. And this is
Yeah.
how it will be to like request the prescription again. Like what
Yeah.
is like for you and that person to like talk about that in the room together. So I think that's the most unsettling piece, that a person calls for a refill and then maybe you feel uncomfortable about it and maybe you want them to come in, but you didn't quite maybe say that at the last appointment. So they
Yeah.
weren't sure. So then if they
Mhm.
didn't know that, then they get a little upset because they're like, why are they having me come in again?
Right.
Right? But if you can
Right.
make that very clear when you meet them, that that's what's going to happen going forward.
Definitely. Yeah. And I think you and I talked a little bit before we started. This is like not an episode about controlled substances. Like there's a lot to say, I think, about the management of those in terms of like best practices of like safety and collaboration with patients. But just using an example, it's just as like as a particular example of like, I think what it brings up for me is like remembering when I was a new grad, and maybe you see this in these people now, but, and you and I have talked about this, but it's like so much of medicine is this long game of patient-centered stuff, which I think really ties into the next piece about the, if I don't want to treat something, because it's like if you zoom all the way out, as scary as all of those facts are, that you have this license and that somebody can die from, you know, some controlled substance, right? Like if you take that off the table for just a second and then you zoom out and you see this person has been taking this regimen for like 5 years, they're stable, like all of these other things, you've done all the safety things, they have, you know, Narcan, I don't like using brand names, but basically like, you know, Narcan at home. What are all the protocols around controlled substance management? Like if they've been doing all of those things, like the long game is that we want to support their well-being. We want them to be functional, have functional ADLs. And that's just the thing, especially with chronic pain, is like, you just need to live your life because the chronic pain usually isn't going to go away. Right. So it's just like, how do you manage it? And if this is managing and it's safe, right? Like, yeah. So I think it's just so much of it. When I was such a new grad, I was just looking at that one visit and I remember, you probably remember a burn person that had a lot, very high pain medicine. I remember that. I think it was like week 3 and there was like all the pain meds. And I was like, wow. And I just, the thought of this person coming back in 3 months, like blew my mind because I was new, you know, and I was just like, is he going to make it? And then, which is a ridiculous thing to say. Like he was totally fine. But it, like in my mind, that's the logic that was there. So, and I think it's really hard to appreciate when you're a new grad that this is a real long game. And so much of this is like conversations with people of what they're willing to do and not willing to do, because like we don't really actually have that much control. We only have control over what we do, right? And what we prescribe or not prescribe, but like people are going to do what they're going to do. So, So how does that conversation happen? I guess maybe I'll just throw out another scenario of somebody who, and just feel free to chime in if there's differences that you're seeing. But I think there's a combination of, I'm trying to think of a specific patient, de-identified, of course. I think somebody who would come in and I would see their number. So for example, someone with diabetes and their A1C is 12, and I'm looking at their regimen and I'm like, like they need their eye exam, they need their monofilament, they need, they need to see, do like foot exam, like foot specialist, like all the stuff. And they're on this meds and like, I don't like that med regimen. That's not like guideline. This is my like judgy, like brand new grad mind. So I'm just letting it rip here.
Who's doing this, right?
It's like, how did they get on those meds? This isn't working. And I would go in and I'd be like, all right, we're going to make some changes.
Yep.
I'm just gonna laugh at myself because I think a lot of people also do that. So I'm just being honest. And then I learned kind of slowly, gradually over time, this person's A1C was still 12, still 12, still 12. And I was like, okay, like what's going on here? You're not going to your eye appointment. Like, what about the med changes we talked about? What about your blood sugar monitoring? Like, yeah. So maybe that's the scenario, and I'm bringing that to you. What is your conversation that you're having with the new grads? Is that apt? I don't know.
Oh, definitely. Yes. Right. And I think it's the initial shock of seeing like a 12, right?
Yes.
Of being like, oh no. Right. And
this is my responsibility. This is on me to manage it. This person could die.
Exactly.
Right. It's still coming back to that same reactivity.
Yes. And I'm happy you just said that too, right? Because I feel like it is taught too that we have to then tell that person that you could die. Right. Yeah. And
hey, I'm a brand new grad. We just met. You're going to die. Just need to let you know. Right? Like I was such a nut when I said all the things that I needed to say on paper. And I was like, that's not the time.
It's not the time. No, it's not. No, right? And it makes them not want to come. I know, right?
Yeah. But it's like, it's a yes and, right? Because it's like you are, and this person, again, zoomed out. Sorry, I keep interrupting you. Go ahead.
No, please. This is yes, right? And it is so basic, the response, right? Of just like, we just go and we talk to the person.
Yeah.
Right? Like
which is a skill to develop. I just want to normalize. Like I feel comfortable now. I did not feel comfortable then. Just basic, talking to people was so scary.
Exactly. Yes. And I say basic, not meaning that it's an easy,
right. Like simple.
Yes.
Yeah.
Yes.
Simple, right? Not easy.
Yes. And like, I feel like with most anything, right? When you go into the room and then say like, so, hey, like the A1C is 12, right? And then you pause, right? Because many people also maybe don't know what that means, first of all, right? So it's pausing to see like, hey, what do you like understand about your A1C, or how do you feel with your diabetes, right? People always have something to say, right? That is why they are there, right? Yeah. So that helps guide the whole rest of it, is just seeing where someone is at and then asking, what would you like to do, right? Yeah. I say like, always, yes, of course, like we have our recommendations, right? But before I say anything, I say like, what would you like to do, right? Yeah. What could we think about with this today? So just reminding ourselves, right, that like, yes, we want to think about insulin, right? When someone's A1C is over 10, right? But most people are very afraid of insulin, right? And like how to have that conversation is not like we need to use insulin, or like you could die, right? Or lose your eyesight, or like your kidneys, right? It's like having those conversations like about risk without the fear piece, right? And like every situation, of course, is different, right? When you go in and you talk with somebody about whatever the diagnosis is, but just talking to somebody first and seeing what they think, right? And then after they share with you how they feel, right, you say like, okay, so like we have options, right? This is what we're doing now. Like, would you like, because everybody, I think especially when it comes to diabetes, right? So many conditions are very similar to type 2 diabetes in that sense, but I feel like we see that a lot here.
So
but
much.
The fatigue of medicine, right? Because like at diagnosis, you're given usually like 3 medicines from the beginning, right? And what that's like from the very beginning, and how to like have that conversation. And I feel like when you get to have a conversation and tell somebody like the why behind the recommendation of like a statin, right? Like, what is this, right?
Yeah.
And just telling people that we have all of these options that can help support your body.
Yeah.
And is that something that you want to do?
Right.
And then, I think just like that. Right.
I
But
mean, and I
it's
just
hard.
like, it's so novel in a way because I like, maybe schools are different now, but I don't feel like I ever talked about that in school.
No.
And I'm still feeling that inner gripping of my new grad self of like, but, you know, but like the moral of the story, the long game of medicine is they get to decide what to do with their body.
Yeah.
And I think it's the same thing as controlled substances where it's like safety first. And I think I actually do that. Maybe that's just my system of when I see patients, because sometimes, like you said with the example earlier with like heart failure and the rash and I can't remember what the other one was, diabetes maybe. It's like, okay, what is what is the most important thing of safety to make sure that I've discussed with the patient? I can document that, right? Monofilament can wait. Eye exam can wait, right? Do they understand hyper and hypoglycemia? Great. Do they know how to take care of it? Great. Right from there, like, you know, we can talk about more things, but it's like, okay, if we've covered safety, I'm asking you what you understand and what you think and what you feel about it. Like that's going to lead, right? Because we literally can't do anything else aside from make our recommendations and if they're willing to hear it or not. And I think the thing that's also coming up to me in this conversation is like, and especially in this situation is my therapist and I were talking about stages of change. And just to reapprise people, there's pre-contemplation, like I'm not ready to think about it. Contemplation, I'm thinking about it. I think the next one is preparation. The next one is action. And then the last one is maintenance. And I feel like I learned that in school and I was like, whatever. But it came up in the context of my real life where it was just like an interpersonal thing. And it's like contemplation. One thing that like just hit me like a rock where she was like, contemplation can be forever. There's no guarantee that somebody goes 1, 2, 3, 4, 5. You can like, there's no limitation on contemplation. Somebody could be thinking about it forever.
Yeah.
And so, and also sometimes if we ramp things up too fast, like this is what my therapist was saying, whether it's an emotional change or a communication change or a medication change, but it's like sometimes if we ramp things up and we're in contemplation and we're in the preparation stage, if it's too intense for us, we can slide all the way back to pre-contemplation.
Yes.
And this is like, and as much as we can bring non-judgment to it of like, this is just the process. So like if we walk in and our brand new patient and we're going to throw all this stuff at them, we've just probably shocked their nervous system to the point where they're going to go back to pre-contemplation of, you know, who knows what. Maybe they were already on their way to change. Maybe they already have been working on dietary stuff, you know, maybe, you know, XYZ. So, I think it's just so, these two examples in particular, I think are real skill sets for people to build. And it's a hard perspective to have, but I just love that we can share this with people because these are the kind of intangibles that you need a mentor for, you know, and for people who are in clinics and they don't have that kind of mentorship, it's like, it's like a whole skill set of just having a conversation, right? Because you're trying to manage your time and, you know, all that stuff. So I love that. But yeah, like I think you and I were talking about that, just so much of medicine at this point, especially primary care, is like meeting people where they're at and what they want. And like, ultimately, I think we have our agendas about like making health better and the healthcare system better and, you know, health of people better and preventative care and all that. But it's like, at the end of the day, everyone's an individual. So
Definitely. You saying the word partnership really like speaks to me, right? That is our role as like, as I don't like the word provider anymore. I'm trying to figure out different words, right? Like clinicians, right? Or like that we're like facilitating health.
Yeah.
And
like we have a knowledge and expertise, but we're ultimately a facilitator because they're a participant, active participant. I mean, maybe they're not active, but it's not us controlling them. It's not us doing things to them.
Yeah. And hearing you say that reminds me, like in the beginning, something I think about is like, I would see folks that would still come every 3 months, like maybe for their A1C. And maybe it, like you said, maybe it always was like 12 each time. And sometimes I'd be like, why are they still coming? Right? Like, I'm so curious about that, right? Or being like, they don't maybe want to like, they're not ready, right? It's not they don't want to, right? Like they're coming, right? They're making the appointments and they're being there. But it was interesting for me in the beginning to figure out, like, I wonder why like somebody is like still coming if they maybe don't want to like take medicine for it, right? Because I definitely have some folks that I've known for years who don't want to treat something, and it's mainly diabetes, but still would like to come to check it up, right? And
Yeah.
that's them treating their diabetes,
Yeah.
right? Because they want to come back and see how it is. And it took
Yeah.
me a while to feel like, what is this, right?
Yeah.
Like I was so
Yeah.
confused, right?
No, yeah. I appreciate you
But
sharing that example because I think it's like, it's hard for us from the clinician standpoint to like, well, if you want to treat something, it's X, Y, and Z, and it's, simple, but it's not, right? And it's like, it's almost like we talked about a little bit about harm reduction, and it's like, maybe that is a harm reduction because it doesn't look like they're doing much, but maybe they
yeah,
are maintaining, maybe coming to the visits and seeing their A1C is maintaining it at 12,
yeah,
but maybe it's not 16. Maybe
yeah,
it's not, maybe they're not being hospitalized. Maybe this is what's keeping them out of the hospital,
yeah,
which like isn't the best, our quote unquote best standard of
yeah,
care in terms of the metric of that, disease process, but we're
yeah.
reducing harm. We're helping them live their lives.
Yes,
So
exactly. Yes.
I love that. Do you have any, thank you so much for your time. Do you have any kind of like parting words of wisdom or pearls of practice? I always like to just throw that out there. If there's anything like hanging over your mind.
Well, I think as we talked around like the themes of what comes up, right, or the themes that at least that I hear, right, I think one that we didn't talk about is like mental health conditions as well and diagnosing and treating. And that is really like common to come up also like as a concern in the beginning of practice too. Like how am I diagnosing something correctly when it comes to like maybe like a complex mental health condition or doing the right treatment plan? I feel like that's the one that I also hear a lot about as
Oh
well.
yeah.
So just to like say that out loud for people, right? That like it's you're not alone, right? That other
Yeah.
people feel the same. And we have specialties for a reason. I can speak to the primary care world. And I feel like sometimes PCPs feel like sometimes a little lost, right? Because they
Yeah.
have like the psychopharm background, but
Yeah.
not all that specialized training that our colleagues do. And
Yeah.
in PCPs, like somebody leaves the hospital and maybe they're started on a medicine and then they're coming to us for the follow-up, but they don't have a psychiatrist,
Yeah.
right? So like, it's like, I totally feel you. And sometimes that doesn't like feel great because you're like, oh, I'm not like the right person to see this patient, right?
Mm-hmm.
But to remind yourself that like you totally are,
Yeah.
right? And like we help like stabilize someone, continue their treatment and get them to somebody else. I feel like that's the other big theme that I hear about that maybe isn't covered as much in school or where you went for like your clinicals. But
Yeah. And
yeah,
I love you bringing that up. Because it's almost like another harm reduction thing. I talked about it in at least one other episode with Daniel, the pulmonologist, because he was talking about practicing as a pulmonologist in more like rural settings. And it's like, it's not on us to take on the dysfunction of the healthcare system and like overextend beyond what we have capacity to do or what is safe because of the healthcare system's shortcomings. And there are harm reduction ways that we can support a person within our scope of practice that is appropriate in primary care and connect with the specialists. And I think that it reminds me of the MCPAP is the one that's coming to mind for Massachusetts, and that's for
yeah,
kids, but it's like Mass Coalition for Psychiatry and something, pediatrics.
yeah,
I'm not
yeah,
sure. But
yeah.
then I think there was like another one that you brought up about like an addiction medicine or
Mc,
pain medicine
yeah, McSTAP.
consultant.
It's like
Mixed
the
up.
same kind of thing, MCSTAP, right?
Yeah. So those are resources for Massachusetts, but, and that's one for kiddo. And I think you said that there was maybe one developing for postpartum. I don't know if that was you that
Yes.
was saying that,
Yep.
but yeah, so I think that like maybe one potential resource to point to is hopefully your clinic has knowledge of your state-based resources that can be helpful, like the STD, the Sylvie Rattel hotline. Am I saying that one right?
Yeah. Yeah.
That's for
Yeah.
STI
Yeah.
management, and that's like if you just Google Sylvie Rattel STI hotline, like there are just and like gender affirming care. There's like a national. There are all these different resources, whether they're state-based or national, that can
Yeah.
be a consultant on a case of like, hey, I really need support with like this. So,
And the
so
one
yeah,
for
thanks for
HIV
that.
care that I absolutely love is the UCSF one. Like they have an
Yes,
HIV like warm line they call, right? Where you
I love
call and
it.
you talk like somebody literally talks to you within a half an hour. How cool is that, right? That someone's
So
calling to
good.
like talk through like HIV like guidelines and treatment with you. Right. There's a lot of cool resources out there. Does it make it easier maybe in the moment, right? But knowing
Yeah,
there's a lot of resources out there.
totally. Well, thank you
Yeah.
so much. I really appreciate it.
I appreciate you. Yes.
Absolutely.